Friends, today's session is going to be a continuation of the last month's or last week's session uh, related to basics of ECG. The first 5 minutes, I'm just going to run through what we learned last week. So it'll be like a recap, and then we will move forward. The last week, we had gone through the basic principles and the normal waves. So today we will see the intervals in the segments and about electrical axis. So what we had understood is that ECG is behaving like a galvanometer, where it can detect and record an electromagnetic potential. It has a positive and a negative electrode, and the imaginary line which joins these electrode forms the axis. Related to the electrical field, we have the frontal and the horizontal plane across which the leads are placed. And every single lead is giving information about particular area of the heart. So we can understand that the coronal or the frontal plane has the leads 1, 2, and 3, which are the standard leads, means they have a positive and a negative end. Whereas the unipolar leads are having only the positive electrode, and they constitute the AVR, AVL, and the AVF. Coming to the horizontal plane, all the leads are unipolar, starting from V1 to V6, and this gives us information about the horizontal axis. That means right, left, in addition to the enteroposterior understanding. A little about the ECG paper. We had understood that the normal speed is 10 millimeter, 25 millimeter per second, and hence we have 5 large squares in 1 second. 1 large square means 0.2 seconds, and 1 small square is 0.04 seconds. This is related to the x-axis. Related to the y-axis, the normal standardization is 10 millimeters, and hence we have a big square as 5 millimeters, a small square is 1 millimeter, which is 0.1 millivolts. Coming to the normal waves and intervals, we understood that the atrial and the ventricular activation happens in a very different way. The atrial activation happens in a contiguity, and the ventricular activation happens simultaneously from the endocardium to the epicardial surface. So it's synchronous, whereas this happens by contiguity. That means the proximal parts are activated before the distal parts. Also, we understood that the electromagnetic forces which are directed towards the positive electrode will give us a positive deflection, towards the negative electrode will give us a negative deflection on ECG. Heart behaves like a 2-chambered heart and not a 4-chambered heart, and hence we have activities which are related to the atrial activation, depolarization, the P wave, the ventricular depolarization, the QRS, and the ventricular repolarization, the T wave. And then we know that there are a few segments and intervals which we will look into detail today. The P wave activation is the activation of the atria, which is contributed by both the right and the left atrium. This is in the frontal plane, and the net vector is downward and towards the left. In the frontal plane, the best P wave is seen in lead 2, maximum amplitude of 2.5 and duration of 0.11 seconds. In the axial plane, the net vector is towards the left and posterior, and this gives us a typical diphasic wave in V1, and the maximum duration should not be more than 0.08 seconds. Coming to the PR interval, the PR interval is the beginning of P to the beginning of Q. It includes the P wave and the PQ segment. The PQ segment means this is the delay of the impulse at the AV node. The duration varies from 0.08 to 0.12 seconds. An important thing is older the person, slower the heart rate, longer the PR interval. This is in contrast to the QT interval, which we will see today. The QRS complex is primarily the activation of the interventricular septum, where the net vector is from right to left, which gives this typical QR pattern in V1 and RS pattern in QR pattern in V6 and RS pattern in V1. The transition, we spoke about the transition last week, which is the equal amount of RS in V3 or V4, and the RS progression from a dominant negative to a dominant positive QRS happens after 3 years. However, younger than 3 years of age, it is going to be complete reversal. That means this is going to be dominantly positive and this is going to be dominantly negative. The RS progression can be very well understood by quantification of RS ratio, in the sense that the RS ratio is larger in right precaudal leads in V1 and it's larger in V6 in adults. This is in infants, and this is not affected by any calibration factor. We also understood a little about the Q wave and the T waves. The Q wave, as we understand, is the depolarization of the interventricular septum. Q waves are commonly present in V5, V6. Usually the amplitude is 5 millimeters and the width is 0.02 seconds. The T wave is ventricular repolarization. It's in the same direction of QRS. The amplitude increases till adolescent period and the V5 amplitude is more than V6 amplitude. Now we will start with the next thing, which is the ST segment. So the ST segment is the end of the S to the beginning of the T. And this ST segment is usually isoelectric. Isoelectric means what? It is in the same level of the PR interval and the TP segment. But sometimes it can be 1 millimeter elevated or depressed in the limb leads, or 2 millimeter elevated or depressed in the precaudal leads. Last time also we understood, when we were learning about the QRS, we understood that the deflection could be a little more prominent in the precaudal leads. So here also up to 2 millimeter changes, elevation or depression in the ST segment in the precaudal leads is acceptable. What does ST segment mean? ST segment is happening after the ventricular depolarization and before the ventricular repolarization. So it's a phase in between ventricular depolarization and repolarization, and you can have changes which are more related to a myocardial disease, a pericardial disease, and few medications. So what are the morphologies of ST segment? We can see the ST segment can be elevated like this. The ST segment can be depressed like this, or you can have a short ST segment, hardly seen, or you can have a long ST segment. So the abnormalities in the ST segment are basically summed up this way. You can see changes in the ST segment when there is pericarditis, myocardial infarction, or ischemia. It can also be seen with digitalis, and it can also be seen with changes in the potassium level. Now with this, now we go down to the QT interval. Now as a pediatrician, I feel QT interval, most of us understand it very well. QT is the beginning of the QT interval is the beginning of the Q to the end of T. So it is including the ventricular depolarization and the repolarization. QT interval is best seen where you see a Q wave, which we know that it's seen very well in V5, V6, and also sometimes in lead 1, 2, and ABL. In contrast to the PR interval, the QT interval does not change with age, but it does change with the heart rate. QT interval shortens with tachycardia and increases with bradycardia, and hence the Bassett's formula. We know that the corrected QT is calculated as QT divided by square root of RR interval. And the normal QTC is usually around 0.4 to 0.44 seconds, and you do not expect it to be more than 0.44. But in younger babies like neonates, you can have it up to 0.48 or 0.49 seconds. A very rough way to calculate QTC is if the heart rate is around 60 to 100, QT should not be more than half of RR interval. RR interval is between the two consecutive QRS complexes. So it should not be more than half of that. Now, what abnormalities can be there in QT? All of us know that there's something called prolonged QT. So similarly, there can also be something called shortened QT, which is not that commonly thought of. Prolonged QTC, two most important causes would be hypocalcemia and certain syndromes like Romanov-Ward syndrome or GLN syndrome, which is associated with deafness. It can also happen with cardiomyopathies and myocarditis. On the other side, you can have short QTC, very commonly with certain drugs like digitalis or hypercalcemia. So I think these are the main causes where QTC changes. Wherever the ventricular depolarization and repolarization is going to make a difference, the QTC changes. Coming down to the last wave, which is the U wave, which we usually do not pay attention to, but there's little which we need to understand is, what is a U wave? A positive wave after a P wave in the same direction of the T wave is called U wave. U wave is always in the same direction of T, and it's the wave which happens after the T wave. Whenever you see a U wave, do not include this wave in calculation of QTC. So your QTC should include the QT interval which ends at the ending of the T wave here. So as we can see here in this ECG, the heart rate, if I try to grossly calculate 1, 2, 3, 4, 5 and 6, the heart rate is around 50 and my QTC is less than half of the RR. That means my QTC is going to be most likely within acceptable limits. This U waves can commonly be seen in children, but we need to be understanding that it can also be seen when there is hypokalemia. So now just to summarize the waves and the intervals and the segments. The P wave is the beginning of the P and the end of P, which denotes the atrial depolarization. The PQ segment is the delay in the AV node. The PR interval, beginning of P to beginning of Q, including the P wave in the PQ segment. The QRS is beginning of Q to end of S, which indicates ventricular depolarization. The ST segment is end of S and beginning of T. And T wave is beginning of T to end of T, which is ventricular repolarization. The QT interval beginning of Q to end of T. And in case U wave after the T wave, which is in the same direction of T wave. Now with this understanding, we will move on to the electrical axis in detail. Before we go there, all of us know that many congenital heart diseases, when they are described in our textbooks as pediatricians, when we go through it, they will use this word of rotation, counterclockwise rotation, clockwise rotation. So I just thought the next two slides are going to give you a little basic understanding about the rotation, though in practice, we don't use it to differentiate the heart diseases on ECG. Now, the rotation of the heart can be understood in two planes. One is this plane, which is the frontal plane. So if I look at the frontal plane, I have to understand and imagine a line which goes across the enteroposterior axis. So imagine a line going through the enteroposterior axis and the rotation is happening in frontal plane. So if I have a heart which is horizontal heart, the heart is going to look like this in a frontal plane. This is the red line is the imaginary line across the enteroposterior axis. And if I have my heart which is horizontal, then my QRS complex is going to have a net vector leftward. This is in the frontal plane. So all of you know that this needs to be seen in leads 1, 2, 3, AVR, AVL, AVF. And if I have a heart which is horizontal, then I'm going to have a QRS axis which is inferior, directed towards the umbilicus. This rotation is not very difficult to understand. So the frontal plane rotation across the anteroposterior axis is easy to understand. You have a leftward QRS axis or an inferior QRS axis. Coming to the next axis, which is the longitudinal axis. Longitudinal axis means, imagine that this is from superior to inferior part of the body, this red dot, and you are viewing from the leg end of the patient. This is the axial section of the chest. And this is the cardiac mass. So if you're looking from the leg end, this is the right side, this is the left side, this is anterior and this is posterior. Now imagine that your line is passing across this point and your rotation of the whole mass has to happen across this axis. In that situation, if my heart is counterclockwise rotated, or it is used as anti-clockwise. So if it is anti-clockwise or counterclockwise rotation of the whole cardiac mass, you can see that the left ventricle comes to lie anteriorly. In contrast to that, if my cardiac mass is rotated clockwise, this way, then my right ventricle will be more anterior. And how do I see this on an ECG? So you need to see in the precordial leads. This understanding, we know that we have leads from V1 to V6 and we need to see from V1 to V6. How do I understand if it's a counterclockwise rotation? I will have my transition earlier in V2 or even V1. And if it's clockwise rotation, then I have my transition as late transition. Late transition means it happens in V5, V6. All of us know now that the transition normally happens in V3 and V4. If I have an early transition, I would tell it as counterclockwise rotation, and I understand that LV is more anterior. If I have a late transition, it is clockwise rotation, and I know RV is more anterior. I usually use this method, L and L. Clockwise is late transition is RV. Now with this understanding, we will move on to the next third part of the basics, which is the electrical axis. Now normally, whenever we think about the electrical axis, we would think about only the QRS. But axis is true for anything on the ECG, like a P wave, a T wave, and also even an ST segment. The first thing which we'll try to understand is QRS complex. The axis of QRS, whatever we understand for it, the principles will hold true for the P wave, the T wave, or even the ST segment. Now, before we go into the axis understanding, one most important thing is the axis can be affected by the weight of the ventricles, the dominance of the ventricles. And we know that the dominance of the ventricles is different in younger children and it's different in adults. Why is it like that? If you see this, the ratio of LVs to RV in an adult heart is 2.5:1. But at birth, it's not the same. RV is more dominant than LV with a ratio of 1:0.8. This RV dominance, which is seen in an infant, gradually changes to LV dominance in an adult. We have RVH in an infant, we have LVH in an adult, and hence the QRS axis also changes. In children, we have a right anterior axis, and in an adult, we have a left posterior axis. This in the horizontal plane. Whenever we are talking about anterior and posterior, we need to understand that this can be understood only in a horizontal plane. The frontal plane gives us an understanding about right, left, superior, inferior. And the horizontal plane gives us an understanding of right, left, anterior, and posterior. Between 1 month and 3 years, you can have an ECG which is in between. Now here we usually use the word 3, but you can have till 8 years of age certain changes which are dominant, persisting till 8 years of age. And we will see in the last slide before we sum up everything at the end of axis, we will go through this. Now the QRS axis. Now, what decides the axis? We know that. The activation of the ventricles, again, we know that the activation happens in a synchronous way, and there are multiple factors which work together from the endocardium to the epicardium. So what decides the QRS axis? It's actually the mean dominant vector. So whatever we have this going from left to right, we have this going from right to left, but the dominant will be from left to right, then that's what is going to be determining the Q wave direction. Similarly, the whole ventricular mass, if we see here, we have these vectors on the RV going from left to right, but these vectors from the LV going from right to left, and if LV is the dominant one, our dominant QRS is going to be from right to left. So remember this, the mean or the dominant direction of all the vectors together is going to be expressed as mean QRS. And how do I understand the QRS axis? I can understand it based on the 6 frontal plane leads. Now, why is it that it's frontal only? Not really. It can be also in a horizontal plane. So first we will put our thoughts together in the frontal plane. But remember that even the horizontal plane is equally important to decide the axis. Coming back to this figure, we all know this, that the frontal hex axial reference system is made this way. We have the 3 standard leads, the lead 1, the lead 2, and the lead 3. And then we have the 3 augmented leads or the unipolar leads, the AVR, the AVL, and the AVF. Now, we have decided this is only an empirical understanding. This is just a design which is man-made, where these degrees have nothing to do with the positive, negative poles of the leads which we understood in the last session. So we have just constructed this system where we have denoted this as 0, and then we go to 90 degrees plus 180 or minus 180, and then coming back to 0 degrees. So if we compare this with this figure, lead 1, the lead 1 is in this direction, lead 2 is in this direction at 60 degrees, lead 3 is 120 degrees, AVR is minus 150 degrees, AVL is minus 30 degrees, and AVF is plus 90 degrees. Something which is very catchy, we have distances of 30 degrees here. However, we can see here that lead 1 and AVF are at 90 degrees. Similarly, lead 2 and AVL are at 90 degrees. And similarly, lead AVR and lead 3 are at 90 degrees. This concept, we will use it while determining the axis. Now, whenever we think about a lead, we need to think in terms of the polarity, in the sense that what area does it make positive and what area does it make negative. Now we know that for lead 1, this is positive and this is negative. So I divide my circle into semicircles. This half for lead 1 is going to be positive and this half is going to be negative. Similarly, if I come for AVF, I know that this is positive for me and this is negative for me. So the lower half circle is positive AVF and the upper half is negative AVF. Now similarly, if I try to think about lead 2, I know that lead 2 is positive here and negative at minus 120. So I make my half circle this way. This portion is going to be lead 2 positivity and this portion is going to be lead 2 negativity. So now with this understanding, I will try to decide what is the QRS complex axis. I know that lead 1 and AVF are perpendicular to each other. So if I use 2 leads which are perpendicular to each other, it can be even 2 and AVL, 3 and AVR, then it helps me to decide grossly the quadrant of the QRS axis. because this quadrant I'm having my lead 1 and AVF both positive. This quadrant I'm having 1 and AVF both negative. Here I have 1 negative but AVF positive. And here I have 1 positive and AVF negative. So with this understanding, if I get my net amplitude of QRS, how do I get my net amplitude of QRS? My QRS will have a positive deflection and a negative deflection. So I will subtract the negative deflection from the positive deflection. For example, if I have a negative deflection of 3 millimeters and a positive of 7, my net amplitude will be 7 minus 3, which is 4. And then the vector is parallel to a lead, then maximum positive upright deflection will come there. If, for example, I have my maximum deflection in lead 1, then I know that my vector is parallel to this lead. And if my vector is perpendicular, I have an equiphasic deflection. If I have my vector going like this, then in lead 1, I have an equiphasic. That means equal positive, equal negative. Now let's take this exercise to understand what we saw in the previous slide. Find the net amplitude of QRS. Now my QRS is having a positive deflection in lead 1. For example, 10 minus 3, which is 7. So in lead 1, my QRS is positive 7, which is, I plot a point here, 1, 2, 3, 4, 5, 6, and 7. So I draw a line from this point vertically down. Then I go to lead AVF. I try to find a net amplitude in lead AVF. For example, it's plus 8 minus 2. So it's 8 minus 2, which is 6. So I again go and 1, 2, 3, 4, 5, and 6 small squares, and I draw a horizontal line here. The point where this line meets is going to be the axis of QRS. I can run this once again. How do you find the QRS axis? First, you go and see the net amplitude in lead 1. Then you see the net amplitude in lead AVF. You plot a point counting the small squares after the central point, and then let it join, connect this connecting point to the central point, and that is what is going to give you the QRS axis. So generally, if it is positive in 1 and AVF, I know it is in the left lower quadrant. That is a gross understanding. But if I want a finer understanding about QRS, this is how I can plot. I also know that if my vector is across this direction, it's going to be maximum positive deflection in 1. But if it's going to be perpendicular, I'm going to have a equiphasic deflection in lead 1. So this is what, if I have a maximum deflection, then I have the vector going towards that. If I have a maximum deflection in a negative way, I have it going away. This is just AVF for an example, because AVF goes like this. It is positive here, negative here. So if in AVF I have a maximum positive deflection, I know my vector is going downwards. If I have equiphasic wave, then I know that it's perpendicular to AVF. And if I have it in between, a mixture, then I know that it's somewhere in a slanting direction. It can be a partly positive, or it can be a dominant negative. Now this is just a revision, a recap. If I have a positive QRS in 1 and AVF both, then my quadrant is going to be left lower. If I have a positive in V1 and negative in AVF, it is going to be a left upper quadrant. If I have negative in 1 and positive in AVF, it's going to be right lower quadrant. And if I have it negative in 1 and negative in 1 and negative in AVF, it's going to be the right upper quadrant. So this is just to locate the quadrant. Now with all these understanding, how do I systematically approach? The first thing what we do is locate the quadrant. So 1 and AVF are easy, but for that understanding, you can take any two leads which are perpendicular to each other. 1 and AVF comes easily for us. So first you decide which quadrant you are having the axis. Second, you see if there is any lead where you have an equiphasic QRS, same proportion of positive and negative deflection. Then the QRS is going to be exactly perpendicular to that. Now here there shouldn't be any confusion about positive and negative. I'll go back to that figure for you to understand that. In this, if I have it equiphasic, for example, equiphasic in AVL, then I know that it's going to be perpendicular to AVL, which could be plus 60 or it could be even minus 120. But before that, I've already decided my quadrant. And if my quadrant is left lower, I know that it's going to be plus 60 and not minus 120. So that's why we locate the quadrant first and then take clues from which is the lead which has equiphasic waves. After that, I can actually also pay attention to a strong positive greatest QRS deflection. Whether it's positive or negative, doesn't matter because I already know my quadrant. So if I have the greatest QRS, for example, at in lead 1, then I know it's 0 degree. The QRS axis is going to be the closest to positive or negative limb of that lead. So this is how, based on all three, I have a fair understanding. I want to accurately plot it. We already understood that. I count my positive and negative numbers in one and then AVF and then jot it down and then draw a line. Practically, it may not be possible to do that. But with this, you will be very closer to an accurate understanding of QRS. There is one concept which is called a two-vector plot. I'm not going to go into details of it, but this is used when your QRS complexes in most of the limb leads are equiphasic. Equiphasic means everywhere, lead 1, 2, 3, AVR, AVL, AVF, everywhere it is equally positive and negative. You have a concept of two-vector plot where I calculate the initial QRS and the terminal QRS separately. We will not go into this detail. What is the normal QRS axis? For an adult, it is 0 to 90 degrees. So it's a left lower quadrant QRS axis, which is normal. However, as we understood, in kids, you have a right heart dominant. So my axis can go up to actually 140 degrees in a newborn. So my axis can be as much as here. So it's usually in the right lower quadrant, a right axis deviation, which is acceptable in a newborn. From 3 months to 8 to 12 years is a gray zone. Your axis could vary somewhere around 90 degrees. So this is what is a normal QRS. What are the abnormal zones we have? The left superior quadrant is termed as left axis deviation, where slight is minus 30 degrees, 0 to minus 30. Minus 30 to minus 90 is marked left axis deviation, but primarily it is left axis deviation. And what are the causes? It can happen with left bundle branch block, WPW and LBH. Left bundle branch block commonly we see in children after surgery. In isolation, it is a very rare thing in children. However, with left ventricular hypertrophy, we can have left axis deviation. And the remaining quadrant is northwest axis. We use the word northwest region. So this is also, you could say right superior quadrant or northwest region. Now, right axis deviation, as we understood, is normal in children. However, it can happen in children with tetralogy of Fallot, right bundle branch block, and sometimes accessory pathways. So these are the abnormal QRS axis. Now, with this understanding, if we are clear about this, we go to the next step because it's just going to be the same principles which we are going to use for P-wave axis. Now, P-wave axis, we know that it represents the direction of atrial depolarization. So what does it tell us? It tells us something about the pacemaker site. If my impulse is coming from the sinus node, then I know that my mean P-wave axis is going to be downwards and towards the left. In the frontal plane, we understood that the P-wave dominant vector is down and left. So my P-wave axis comes between 40 and 60 degrees. And in Axial section, we will see it differently. What is an abnormal P wave axis? If it's less than 45, we say left axis. If it's more than 70, we say right axis. If the P wave axis is between -30 to +70, suspect a congenital heart disease. If the P wave axis is less than 0 degrees, when we say less than 0 means the P wave axis is superior. Superior it goes when you have an ectopic pacing site in the atria. For example, if my pacemaker is not the sinus node, but it is an ectopic beat which is closer to the AV node, then I know that my axis is going to be superior, not inferior and leftward. That is the situation where I have a P wave axis which is in negative numbers, less than 0 degrees. And one more important implication of P wave axis is when I have situs inversus, the atrial situs inversus, either in isolation or with mirror image dextrocardia, my P wave axis is going to be rightward and downward. That means 120 to 150 degrees in the right lower quadrant, because my sinus node is in the left upper area, not in the right upper area. So my P wave axis changes. So importance of P wave axis is to suspect situs inversus, to suspect an ectopic P wave, and in certain congenital heart diseases. Similarly, T wave axis. What does T wave axis mean? We know that T wave means ventricular repolarization. And the T wave axis is the mean vector for ventricular repolarization. Normally, it is like QRS 0 to 90 degrees. However, we know again that age plays an important role. T wave is upright in V1 in the immediate postnatal period. Usually the 3 days after birth, P wave can be upright. It becomes negative from the 4th day and remains negative till few years. Here I have written 4-5 years of age, but usually it is acceptable till 8 years of age. After 8 years, it again becomes positive. So in an adult, the T wave is positive. And in children, commonly, it is negative, which is normal. T wave axis is determined in the same way like QRS and P wave axis, and normally it is 0 to 90 degrees. But what if my T wave axis is not normal? Now, in isolation, if the T wave axis is not normal, the common causes are very similar to abnormal QRS, like ventricular hypertrophy, right or left bundle branch block, any myocardial ischemia, any pericarditis. The T wave axis, now this is a very important understanding. The T wave axis usually moves away from the region of pathology. What does it mean? If I have an insult, for example, I have pericarditis near the apex of the heart, then my T wave axis is going to be away from the apex of the heart. So it is going to be away from the region of pathology. This is important. We will see in the subsequent slide how an ST segment axis changes. Because a lot of times as a pediatrician, when we try to think, we think some T wave changes, some ST changes, elevation, depression, everything is confusing. But these two principles we need to understand. One is the T wave axis moves away from the region of pathology. The ST segment is in a different way. So with this understanding, we come to the concept of QRST angle. That means what? You get your QRS axis, you measure your T axis, and the difference between the two is the QRST angle. What does it do? It relates the ventricular depolarization with repolarization. And normally, we know that the T wave and the QRS should be in the same direction, so we don't want a significant difference in their axis. Any change which is less than 60 degrees is normal. Any angle which is more than 60 degrees is not normal. But remember that the T axis is more important. A wide QRST angle is less significant if the T axis is normal rather than having a T axis abnormal. So do not skip that step of understanding the T axis. Once you finish that, then you calculate a QRST angle. If it is more than 60 degrees, it could be related to a strain with ventricular hypertrophy. For example, if I have severe aortic stenosis with left ventricular hypertrophy, it can be without strain. That means the T wave axis and the QRS axis is in the same direction. Or with strain, when my T wave axis and the QRS axis are significantly different. So this is the importance of T wave axis. Now there is something called ST segment axis. ST segment axis, similarly, you will talk about ST elevation, ST depression. In a similar way, you will decide what is the ST segment axis. In contrast to the T wave axis, which goes away from the pathology, the ST segment axis goes towards the injury. For example, same, if there's acute pericarditis at the apex, my axis is going to be this 30, 40, 60 degrees. But the T wave axis is going to be away from the left lower quadrant. So the T axis and the ST segment axis both behave differently in presence of a pathology. Now, so far, whatever we learned was in the frontal plane. We were looking at the axis calculation in the limb leads and the augmented leads in the frontal plane. We know that this tells us left, right, and superior, inferior. But what about the interoposterior relationship? And that is what we need, the horizontal reference system or the axial system. And we know that here, V1 to V6, we have leads placed like this. This is just a recap. V1, V2, V3, V4, V5, V6, similar to 1 and ABF, which are right angle to each other, V2 and V6 are right angle to each other, where V2 is positive here, negative here, V6 is positive here, negative here. Sort of difference of between the two leads, the angles are usually around 30 degrees. If we try to see the negative positive segments for polarity, this is how it will look. We know V2, the front half circle is positive, the back half is negative. This is anterior, this is posterior. Similarly, V6, the left half circle is positive and the right half circle is negative. Similarly, we try to see V1. This is how the semicircle will come because V1 is directed like this, a little towards the right side in interior location. So this is negative and this is positive. Now to incorporate the anterior and posterior relationship, commonly this is what is advocated, but we commonly don't do it. So these are the figures which are shown, which indicate which direction the QRS vector is going. Sorry. If the QRS vector is anterior, you have to see the lead V2 deflection. This can be used for QRS, T, P, anything. But if you have a significant positive deflection in lead V2, we know that the QRS vector is anteriorly directed. If my V2 has a significant negative deflection, my QRS vector is posteriorly deflected. And if it's equiphasic, it's somewhere in between. It's intermediate. And the figure which you need to incorporate is this, which commonly we don't do it, but I think the understanding is important, where if it's positive, anterior, negative, posterior. Now, with this understanding, we are just going through to summarize about the axis. We got to know that QRS axis normally is 0 to 90 degrees, but in a newborn, it can be up to 160 degrees. So right axis is normal in a newborn. Slowly over a couple of months, it will become like an adult. R wave. We know that there is a positive deflection in V1. That means you have a tall R in right precaudal leads, which is normal. However, how do I understand what is right ventricular hypertrophy in a newborn then? If I have R waves which are more than 10 millimeter in a newborn, or I have a QR pattern in V1, then it indicates RVH even on day 1. So this is important. If I have R waves which are more than 10 millimeters in isolation, or I have a small Q and a dominant R, then it is RVH for a newborn. Slowly this right precaudal lead dominance of R will become lesser and lesser, and it will become dominant in the left precaudal leads. In contrast to that, the S waves behave differently. Here we have deep S waves in V5, V6, whereas as we go in an adult, there are deep S waves in right precaudal leads. And hence we have an RS progression, which in an infant is reversed compared to adults. The RS ratio is more than 1 in right precaudal leads and here it's less than 1 and right precordial leads. The T wave, we know that it should be upright for the first 3 days. It becomes negative and it again becomes positive anytime between 3 to 8 years of age. Yes, so I think this is the summary of all the understanding we had in the last few slides. And this is the end of our today's session on basics. Anybody has any questions, please feel free to ask.